Right.
Good. All right.
Okay.
Should I take it from here?
Yes. See. Yes.
Well, thanks
The floor is yours.
Thanks so much for having me to the working group and to you and Yang, of course. So I will go into the topic. This is about adaptation, obviously, and particularly about GRADE guideline development. I sit on the board and am actually the vice chair of GIN, as you know. That's one of my declarations for sure. Have some other academic roles. I don't have any direct financial conflicts of interest. I have received funding from WHO and other groups, as well as honoraria that I will mention briefly here. The prerequisites for today's presentation are really that people know a little bit about GRADE, so I will not explain GRADE in detail, although I give a brief background. The views that I'm expressing here are my own, and I'd like to declare that there has been lots of help from other people with developing this approach. So I'll focus on using GRADE-ADOLOPMENT for health guidelines. This is a two-part presentation, as you said, Yasser. So part one, which is today, is providing a background and an overview of GRADE-ADOLOPMENT using a couple of examples. And then part two will focus on more examples on practical aspects and on the upcoming GRADE guidance on adolopment, so an updated guidance here. We are preparing an add-on module to GIN's guideline credentialing and certification program that is in GUIDE, which is done in collaboration with McMaster University. Again, so much of what you're seeing here today will be part of the add-on modules there. But just in terms of background, so I said knowing about GRADE will be a background for today. So in GRADE guidelines, we make recommendations that have a certain strength and have a certain certainty associated with it. Essentially, when we ask about the certainty of the evidence, we ask those who do systematic reviews and develop guidelines to answer a few signaling questions. The certainty of the evidence is determined by risk of bias, or what the limitations of the available research studies are, if the results are consistent, precise, how directly the evidence actually applies to the population setting, interventions and outcomes, and if there's publication bias, or if there's all the research that exists, and issues that increase our confidence in the results, such as large effects. The recommendation strength, as most of you will know, is determined by whether or not they are more desirable than undesirable consequences. That goes beyond the benefits and harms, but integrates issues around the actual value that people place on outcomes. That is part of the benefits and harms, the equity considerations, feasibility, resource use, and acceptability. So, and most of you will know how this actually works in the process of developing recommendations. A guideline development group of panel starts with a PICO question: population interventions, comparators, and outcomes. Those outcomes that are critical or important for decision making are analyzed in systematic reviews and health technology assessments. We produce summary of evidence profiles, a summary of findings tables, and rate the certainty then according to the criteria that I described, and then apply the evidence to decision frameworks to actually arrive at a recommendation. And a recommendation can be strong or conditional. Conditional, this is moving forward without me doing anything, which could be that I have a timed presentation, I hope not. So the recommendations can be strong or conditional. Conditional recommendations are also called weak, and recommendations can be for or against an option. And that then ends up in a guideline, in a classic guideline like this one, or in newer tools like recommendation maps. And I want to focus on the actual issue at hand, and that is when there are strong recommendations, Processes such as adultment, which I will explain in detail, should involve checking of evidence and judgments, but usually when a global guideline, for instance, recommends an intervention strongly, it should apply to the local setting. So when you go from a global to a local guideline, adultment or adaptation often is likely to not change the recommendation. Otherwise, the original guideline developer that takes a global perspective wouldn't have made a strong recommendation. Most recommendations, as you know, and I will get back to that, are conditional recommendations. And that means that there is a need for substantial debate with stakeholders, and local evidence and other factors are likely relevant for implementation. The balance is clear when, as I said, the net consequences are evident because the research evidence for criteria and the evidence to decision frameworks is conclusive. That is, you have moderate or high certainty evidence. When the effects are clear, in other words, there's either much more benefit or than harm, or vice versa. When people value the outcomes similarly and the recommendations apply to all, and when costs are not prohibitive across settings. Furthermore, when interventions or the consequences are equitable, acceptable to all, and feasible, we make strong recommendations. And here's a good example of a strong recommendation. All patients who do not have an aspirin allergy should receive 160 milligrams aspirin acutely in an acute myocardial infarction. This recommendation applies with minimal contextualization. And all of you know that we often use the traffic light analogy for this. This is a green light at a traffic crossing. And there's really very minimal thinking, except for the question, do you have an aspirin allergy necessary in order to act on a problem like this? But when is the balance not clear? So which conditions? There's somebody who has some background noise. If you could mute yourself, that would be fantastic. When is the balance not clear? So, can you mute? Somebody is not muted. I will take control and mute everybody who is. Okay. All right. Sorry about that. So when is the balance not clear? And this is where adaptation becomes much, much more likely. So in other words, which conditions lead to conditional recommendations? When the net consequences are unclear because the research evidence for the criteria on the ETD is not conclusive, the effects are closely balanced, people value the outcomes differently, and a recommendation applying to all is not appropriate, costs differ by jurisdictions, for instance, or are too high in some jurisdictions, and the interventions or consequences are not equitable, acceptable, or feasible. And here's a quick example from a WHO guideline. By the way, some of these slides are also available on Open WHO in our tuberculosis courses. A classic example, a recommendation that says chest radiography may be offered to people living with HIV on antiretroviral therapy, and preventive treatment be given to those with no abnormal radiographic findings. This is a conditional recommendation for the intervention. The certainty of the evidence was low, but one of the reasons was clearly that this recommendation can lead to large costs. There are, if it's implemented, more resources required, particularly if a chest X-ray and is not widely available, and it would also increase the possibility of false positives who might undergo further investigation. And the question that one asks, if cost is the determining factor, whether or not one can afford this intervention in one setting. It's a classic yellow light analogy. So these recommendations, conditional recommendations, need contextualization. So what is contextualization? This is a definition that we put out in the Lancet Public Health. There has been lots of talk about contextualization of guidelines and recommendations, yet there was an absence of a definition. So in this paper on the ecosystem of health decision-making, we provided a working definition. So contextualization of guidance or guidelines describes the need for dialogue and formal consideration of the local best available evidence and criteria for adoption, adaptation, or de novo creation of recommendations from an existing guideline to a national, local, or other level. And considerations should be given or made to decide whether these recommendations are right for that setting, and modifying or adding to the recommendations to optimize the implementation using structured and transparent processes. So the considerations then really for contextualization, where adultment is one method for contextualization, as opposed to just talking about adaptation, because adaptation is a way too narrow term, or maybe to define term. Because by default it describes that something will be changed, but changes do not always happen. So the considerations for contextualization are that first of all, we ask what is the strength of the recommendation in the source guideline, and compared to the source guideline, do evidence and judgments actually differ in the context in which I intend to implement the recommendations? That's the question. And I like to emphasize that in many people's view, including in mine, there is no implementation without contextualization. So this process that I'm describing is always necessary. You can make it explicit or you can make it implicit, but it is necessary. If it happens by a formal guideline group or if it happens by an individual applying the recommendation, contextualization takes place when implementation is being done. The reasons for making a recommendation for or against an option need to be understood, therefore, to really contextualize and implement. And adultment is a method to achieve that. So this is from our original paper where we describe GRADE-ADOLOPMENT 2017. And this adultment, a new term added to the clinical epidemiology lexicon, is from Peter Tugwell and Andrew Notarus, who took up this term that we had invented in the EPI lexicon. So, and they correctly stated that the most important basis for updating or adultment is the existence of a trustworthy review that can be used for the judgment by the particular guideline panel. And the efficiency has also been greatly helped by the ETD frameworks that can be completed online. So what are the differences to set the scene for this and the next presentation between a typical adaptation effort and adultment? Adultment focuses on the questions that are relevant or important for a particular stakeholder, and you will see how that works. And it does so by identifying questions for which a recommendation is necessary, and then look for a source guideline and evidence synthesis, as opposed to classic so-called guideline adaptation, which focuses on a source guideline and how it can be applied in a setting. So this typically happens through somebody identifies a topic, then looks for a source guideline and use the recommendations herein. And you will see over this and the next presentation how adultment actually differs starkly from that, by, again, not focusing on a single guideline, but focusing on questions and formulating recommendations that can come from many guidelines or even no existing guideline through existing evidence synthesis, when it is required that certain recommendations are formulated to provide a comprehensive unit for a national setting. This will become, or a local setting, this will become clear as I talk. So the adultment is a method to increase the efficiency in guideline development, yet making sure that the appropriate problems are addressed for a relevant setting. In brief, adoption means that an already developed recommendation can be used as they are, when the information that is required for implement them is either already there or done by a guideline developer. Adaptation refers to that the recommendations have been developed elsewhere and are then adapted to the context that currently needs the recommendation. And de novo synthesis or de novo creation means that there's an absence of a source or benchmark guideline, but evidence syntheses are available. And as you may know, this is from a systematic review that was done by Andrea Darcy and is currently being updated, that looks at different approaches for guideline adaptation, and in those authors' judgment, the adultment process was considered to be the process that is possibly best suited to fulfill those users' needs who need recommendations across a topic, as opposed to focusing on already existing guidelines. So what is the backbone for adultment? I'm starting to talk more about the actual method for adultment. We believe that adultment is facilitated by the actual availability of three core components. That is the summary of findings, such as through a summary of findings table or an evidence profile of the research evidence that focuses on the health benefits and harms, an evidence to decision framework, and the actual recommendation. So these three components facilitate adultment dramatically. And I'll go deeper and deeper over in this presentation, the next presentation, in terms of what this means. So here's another diagram of how to conceptualize it. You have source recommendations, not a single source guideline. And in particular, either through available summary of findings tables, evidence to decision frameworks, or recommendations, or those that are constructed from the source guideline, one would check if there is agreement, in particular when there's some strong recommendations. Agreement with underlying judgments is more likely to be present, and a summary of findings table and evidence to decision framework and the recommendation may not be changed, because the judgments would be the same when an existing or source guideline is utilized in one setting and applied in another. And that would be an adoption of a recommendation. For scenarios where a recommendation is conditional, in particular, as I said, the availability of these three components will facilitate a adultment process. If there's a change to judgments, in particular because of contextual evidence that is available, so local evidence, for instance, that would mean that perhaps the summary of findings table may be the same, but issues around feasibility are different, or baseline risk are different, which may have an impact on the summary of findings table. And it leads to changes in the judgment, in the evidence to decision framework, and the actual recommendation and an adaptation. And the scenario that is extremely relevant is that when you do local or national guidelines based on global guidelines, we've seen this over and over again, there are often gaps in questions and recommendations in the source guideline. That can mean that there is then no summary of findings table, no evidence to decision framework, and no existing recommendation. It's a new question, but it's part of the guideline that one must develop in order to address the needs that are existing locally. It is a new question. It may require a new or existing systematic review, and it will require developing a new evidence to decision framework. But together, these recommendations may form an important unit, and therefore the question must be addressed in order to not leave important gaps. So here one would have a new recommendation for the particular context, and a guideline that results is therefore adult because it has these three components. So however, there's a few things that are relevant. So even if you don't have evidence to decision frameworks fully completed, you can look for the information, and we've done this over and over again, look for information that are akin to or resemble the criteria on an evidence to decision framework and assemble the actual evidence to decision framework oneself. Then also there are often hidden judgments in a guideline that doesn't necessarily have an ETD. In any instance, it is important to add local evidence that might be relevant before one would then implement. So again, just to emphasize, if judgments are similar and desirable consequences outweigh the undesirable consequences, one might adopt and implement an existing recommendation if it was, for instance, in favor. So I'll stop here for a minute and see if there are any questions in the chat or any questions in general before I go into planning and some examples that demonstrate the approach. I don't see anything in the chat. If there is nothing in the chat, then I'll take it from here. Okay, good. So first is planning. So like with any effort of guidelines, of guideline development, adultment requires careful planning. It saves a lot of time and effort and resources at the end, but the planning doesn't go away. So for instance, we've done a number of efforts where we develop guidelines based on global guidelines with ministries of health, or based on guidelines of other countries, right? That requires serious planning. So to set, that includes setting or identifying groups and the appropriate, setting the appropriate roles. Okay, so there's a question, I will get to it in a second. You can ask a question, by the way, also verbally, I guess. It requires prioritization of a guideline topic and actual prioritization of questions. I want to emphasize this over and over again. It is not enough to just take the questions from a source guideline if you want to make your guidelines really relevant for the context. It may require updating systematic reviews and identifying contextual data. It may require preparing or updating grade tables. It requires training in guideline development. So adaptation is also depending on good training of guideline development group members, and then obviously formulation of the rating of the formulating of the recommendations and rating the strength of recommendations. And it should include collecting feedback. There is a question in the chat. Can you please explain the difference between contextualization versus adult guidelines? Okay, I'll return to my slide, Yang, to make this point a little bit clearer. But in a nutshell, okay, in a nutshell, contextualization is defined as the following. Adultment is a method to contextualize. That is the way to conceptualize the whole thing. Contextualization refers to making sure that the recommendations that are in a guideline, that the recommendations are appropriate for the context, right? By considering whatever is necessary. Adultment is a method to do this, which means that people can use other approaches if they wanted to contextualize. Adultment is a specific method to contextualize. That's the way that we look at it. I hope that's clearer. So,
may I chime in? Thanks, Holger.
Sure.
I think my my question I'm not clear about if after using the adultment methods, if the recommendation has not been changed, even considered contextualized evidence without change of the recommendation, it's still a contextualization process and a contextualization of guidance?
Sure, it is, because the process requires that those who use the recommendation ideally based on an existing evidence to decision framework, that those who use the recommendation check the evidence and check the judgment. And if the evidence is the same and the judgment is the same, then they have contextualized it, but in that contextualization, there were no changes. Okay, so contextualization doesn't mean that you must have changes. I gave you the aspirin example. That example will not change across the globe. It will not change, right? Because the evidence is universal. Aspirin costs close to nothing anywhere in the world. Taking an aspirin pill is, if you think of all the ETD criteria, comes with very little limitations, right? So if you consider the intervention in the first place, now you might say aspirin is not relevant in our setting. I think that would be a mistake, but you might say that. But then you would not look at this recommendation. You wouldn't have prioritized it. Once you prioritize it, it will be the same across different contexts. And the reason why it is necessary to still look at it is what we've learned. There's not a lot of research evidence, but what we've learned is that if you, for instance, use recommendations that are developed by other organizations, in the process of using recommendations in a national context, people want to have a say. One of the first studies that was done in this context was an evaluation that we did of the Guideline program in Estonia 5 years after it was kicked off. And one of the most important findings of this qualitative and quantitative work was that those who are involved in using guidelines, in particular in smaller countries, want to check if they agree with the recommendation, even if it's just a checking. So again, to answer the question, a guideline, a recommendation that is not changed, that is adopted, but has been checked for whether or not the judgment and the evidence is applicable, is an adult recommendation and a contextualized recommendation. Again, contextualization does not mean that you either change something or that the local evidence is actually different from the evidence that was used in the source guideline. Yeah, and there's another, there's a few other questions. So Lumna, you have your hand up, and then I go to the question in the chat.
Yeah, I'm enjoying this very much, but I would like to know the limits or the boundaries of the new verb to adolop, or the new noun adolopment. Is implementation part of it, or is it just assessing the evidence and preparing it for implementation, one way or the other, including contextualization? So the point is implementation part of the process of adolopment, or you would like to keep it separate?
Adolopment is part of the process of implementation. So as I said on a subsequent slide, there is no implementation without contextualization. So the contextualization, for which adolopment is a method, is part of implementation. So also referring back to that Estonia paper that we did with the WHO country office there, what became very clear is that implementation of a guideline by others can only take place if a proper process of contextualization has taken place. People do not like to implement guidelines of others without contextualizing them, and adolopment is a method for doing this. So implementation is a long process, right? And the prerequisite for using a recommendation is the contextualization. It's actually part of it.
Yeah, I have no problem with contextualization, but because this term is likely to be used more and more, the adolopment, is implementation part of adolopment, or is it a consequence, another process?
I will say it again. Adolopment is a prerequisite for implementation. It's part of it. So think of it in the following way. In order to implement a recommendation, you have to contextualize it. Contextualization is a is a process, right? It's not a method. It's not a method. It's a process. The method for contextualization is adultment. Okay, contextualization is a process. You say contextualization, we define it, but you need a method to do it. You need to operationalize it, right? All right. You need to actually do it. You can say we contextualize our recommendations, and that means that you need to have a process for doing it, that you need to have a method for doing it. Adultment is the method for contextualization, and that is required in order to implement. For many of us, it is actually part of the implementation process, because I will say it again, I will try to explain it again. Even if you use aspirin based on an existing guideline, you look at whether or not your patient truly has a myocardial infarction, if aspirin is available, etc., etc., if it's acceptable, if it's feasible. You need to check this as a practitioner, right? You do it implicitly in most instances. This is why it's an adopted recommendation. There is no change. It doesn't matter, right, where you are in the world, but you still go implicitly through the process, or if you are a guideline panel, explicitly through the process of saying, all of this is the same. Check, 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 check. That is the adultment. That is the method for contextualizing the recommendation that comes, for instance, from WHO, that aspirin should be utilized in an acute myocardial infarction. Okay, so if you implement, you need to contextualize. How do you contextualize? Using adultment. That's the way to think about the whole process.
Yeah. So in that case, if I may ask again, in that case, what are other methods of contextualization where you think adultment has superseded them? Or
well, nobody has actually, as far as we know, nobody has actually formulated it in this clear and structured way. People have always talked about adaptation, and the adaptation process, as I said on a previous slide, typically has relied on, here's an existing guideline, I want to implement it in our setting. And then what we've learned over time is that this implementation of, let's say, the European cardiology guidelines in Estonia fails because there is no contextualization. Also because there were no appropriate methods, because I will use that very straightforward example. If you have a guideline from a European organization, they don't address the question of interest. Those who actually are the users of this guideline quickly lose interest if they don't find the answers that are relevant for them. Adultment includes a process that prioritizes questions beyond an existing single source guideline. You will see later on that it starts with questions as opposed to with guidelines. So Lubna, to answer your question, the whole process, because there were no existing frameworks that did it in the way, at least in our view.
In a way, you have formalized this when it was not possibly felt and known, but not formalized in a process. So
yeah. So, and then Graziella is asking, is it possible to use the adultment for a topic of different guides that have grade? Of different guides that have, yes, exactly, Graziella, that's exactly the point. Good question. So, excellent. And contextualization versus adaptation, they are not synonyms, absolutely not, from Yasser. What about setting a guideline for rare diseases? Applies for rare diseases in exactly the same way, may actually be more relevant because of baseline risk differences and so on. Yeah, so those were the answers in the chat. So let me give you a quick example. So we ended here. I'll give you one example, and then, as I said, in the next talk, we will have many more. This is from an development effort of American Society of Hematology guidelines that we had done with, as I said, a large number of panels, and this effort was led by Ignacio Neumann in South America. And the Adultman project focused on the following. There were 10 existing guidelines from the American Society of Hematology. The actual guideline panel looked at these guidelines and prioritized 22 questions from the prevention of venous thromboembolism guidelines and 20 questions from the management of venous thromboembolism. So prevention and management, two different things. They did not identify a new question, which was in this case perhaps not very surprising, because the actual guidelines were extremely comprehensive. So what they did was they had access to the original ETDs, and that was obviously extremely helpful. They again did a question prioritization exercise online and in person. They updated evidence for the ETDs, including regional evidence. I will give you an example. And then they formulated recommendations, either adopting or adapting them using the process that I described. So the backbone was the summary of findings table. Here's an example of whether or not one should use low molecular weight or unfractionate heparin in acutely ill medical patients. And again, the patient population were acutely ill medical patients. A systematic review of several trials was available. I don't need to take you to the summary of findings table, but here's the summary of findings table that essentially indicated that there was almost no difference if you used low molecular weight heparin or unfractionate weight heparin for any of the outcomes. You see that here on this side, moderate or low certainty. I don't know why this is happening. Moderate or low certainty evidence. Risk difference, typically 1 or 2 fewer per 1,000, so 0.1 to 0.2% difference for any of the critical outcomes. They looked at, or they considered the values and preferences. The big differences here, the big difference here is that low molecular weight heparin can be administered once a day as an injection under the skin. Unfractionate heparin requires 2 injections per day in order to achieve similar doses and efficacy. They looked at resources across different settings in South America and found that the prices for unfractionated heparin and low molecular weight heparin were actually quite different across different countries. So, for instance, in Chile, unfractionated heparin was much cheaper than low molecular weight heparin, but you also see that in Colombia, for instance, there was price regulation, there was no difference, as an example, right? So quite a few different things to consider. They considered health equity as part of the ETD, and the local studies that they found was that they suggested that lower socioeconomic strata would be disadvantaged because they have less access to the relevant medications, in particular those that are more expensive. Also what happens is that out-of-pocket expenditure may be quite relevant in this particular setting. So the original guideline said in acutely ill medical patients, the ASH guideline panel suggests using low molecular weight heparin rather than unfractionate heparin, was a conditional recommendation based on low certainty evidence. The actual adapted recommendation said that in acute medical ill patients, the ASH guideline panel suggests using either unfractionate heparin or low molecular weight heparin, made this a conditional recommendation. As the original panel, they considered both alternatives likely to be effective and safe. However, the price and access to low molecular weight heparin was very variable within the actual region. Of these 42 questions that they addressed, 8 recommendations changed the direction, 5 recommendations changed the strength. I'll give you another quick example. This is actually the original work where the adolopment approach came from. That in 2015-16, we worked with evidence-based healthcare center in Saudi Arabia for the ministry on a adolopment project of 22 different guidelines, and did this in a fairly short period of time. The first 10 guidelines were done in 10 months, adoloped in 10 months. The second wave of 12 guidelines was done in 6 months. And I want to give you a specific example about so far I showed you an example of where adoption would be the method of choice, the aspirin example. I showed you an example where adaptation, that is a change in the actual recommendation, is an example. I'm now going to show you an example for a de novo recommendation. So the Saudi Arabian guideline panel had prioritized in the guideline that focused on dealing with myocardial infarction. They had prioritized the following question. The question was whether or not when a patient has an acute myocardial infarction and requires an intervention with a catheter to evaluate the vessel and possibly place a stent, whether or not the intervention should focus on only that single vessel that is the culprit, that is the problem, or while they are in there, they should also fix the other arteries that look suspicious. Okay, so I hope the question is clear. So typically when you have a myocardial infarction, there's a vessel in the heart that has either a clot or is obstructed and causes the myocardial infarction. One intervention is to go in there with a catheter and, for instance, dilate the vessel and place a stent. You can focus on that single vessel, or you can also look for the other vessels around it and see, let's fix them as well at the same time. It's a relevant question. It was prioritized by the cardiologist in Saudi Arabia. Now, the guideline of dealing with myocardial infarction that was actually done by NICE at that time offered no recommendation, because they said, we don't think that the evidence is really telling us what we should be doing. We did a systematic review. We found 2 randomized controlled trials for the outcomes of relevance, in this case, all-cause mortality. They found the following, that is that addressing multiple vessels, in other words, looking at several blood vessels there, looks like it's in favor, but we're not going to make a recommendation. Okay. The guideline panel in Saudi Arabia thought, that is really not going to help us if we are silent on this matter. We updated the existing systematic review and looked if there were new studies. And indeed, at that time, shortly thereafter, there were 2 additional studies. And these additional studies, now you have to pay attention because the multi-vessels on the left-hand side, because we did these analyses ourselves. But what you see here is that both for mortality as well as the outcome reinfarction, there were 2 new trials, and it looked like the actual multi-vessel intervention was more favorable, and indeed by a large degree. So what did the guideline, what did we do? We produced a new evidence profile as opposed to the evidence that was previously available. There was now evidence on 1,000 patients, and the actual guideline panel formulated a new recommendation because it would have been an important gap, and an original guideline, a source guideline, may not have a recommendation for many reasons. In this case, the guideline panel of NICE was uncomfortable making a recommendation based on the 2 trials. Other groups would have made that recommendation, even on the basis of 2 trials. an example for a de novo recommendation. In the work that we did here in the first phase, we had 133 recommendations in Saudi Arabia, and this is an example of how often the strength and the direction actually changed. So in 24%, so about a quarter, the strength changed and the direction changed in the adultment process in about 20% of those who could actually be adult. And altogether, this is not obviously adding up, because this refers to when strength and or the direction changed. It was about 38%. So that just tells you that using guidelines by others often leads to important changes if careful processes are used when guidelines by source guidelines are really contextualized. So the way that this works is that, for instance, a conditional recommendation for an intervention may become a conditional recommendation against an intervention, and that should be clearly described. So GRADE Pro, which is Grade's software to develop recommendations, has an adultment module. We'll talk more about that in the future. So ideally, evidence to decision frameworks are shared, and we have quite a few examples for when this has happened. I'll give you a couple others in a minute. And then this information can actually be utilized with a new guideline panel to say, to provide information of when, for instance, a judgment around values might change. So, and ideally, there would be a rationale for a change in a particular judgment on the ETD framework provided by those who develop in order to make the process again transparent. And this is how this then can look under those circumstances. Here, the judgment on the ETD of the original guideline panel. Here, those that are the result of an adultment process. So, for instance, a judgment about desirable consequences may be different because the baseline risk is different, despite the fact that the relative effects may be similar. There may be issues around indirectness. When you have a source guideline that felt that, for instance, relating to Central Europe, the population was similar to that in the studies. When you start extrapolating, there may be issues around indirectness that has an impact on the overall certainty of the evidence, which, for instance, could then lead to a change in the direction and strength. So these changes in the actual ETD criteria are indicated, and that can then lead again to different recommendations, as I showed in the previous example. But it can also lead to the same recommendation, despite the fact that some judgments are changed. When judgments change, even if the recommendation is the same, we still call it an adapted recommendation. So a couple other examples that we will go into more detail in the follow-up presentation relate to, because it's a really good example, relate to the European breast guidelines. The European breast guidelines are an initiative of the European Commission. And these guidelines that have full evidence to decision frameworks that are prepared by a Cochrane group and then gone through very carefully by the European breast guideline panel. These guidelines all have evidence to recommendation frameworks, as I said, and they are electronically available and therefore can be easily used in an adultment process. They have been used in China, in Chile, and in a whole bunch of European countries, and also by the Ministry of Health in Tunisia. And this is a paper that was published around that, and it was one of the earlier guidelines that actually earlier countries that used the European breast guidelines for it, and they applied this approach that I just described here in quite some detail. I wanted to give a few other points. So in our COVID-19 recommendation map that we've done for with funding from the CRHR and for WHO as well. There is detailed information on the evidence to decision framework, and newer approaches allow interaction with those who develop the guidelines. So for instance, here on our COVID-19 rec map, people can request development and then can receive the information that is available directly through the software tool that we utilize. And then finally, so what we will focus on in the next presentation, this being the background, are the actual detailed steps that I will briefly introduce before we stop, briefly introduce the actual process of development. It starts with the selection of a guideline topic, prioritization of questions, then an identification of appropriate source guidelines. So it doesn't start with the guideline, it starts with the question, with the topic and the questions, just to indicate that if source guidelines are relevant, of good enough quality, relatively recent, and ideally use the GRADE approach, then a matching process of the source guideline recommendations to the prioritized questions take place. If there is a matching recommendation for the PICO question of interest, then systematic reviews are updated as needed. Sometimes that's not necessary. The next question is there an actual ETD fully prepared? If not, one develops an ETD based on the existing information. If there is one reassesses the evidence to decision framework judgment. So for instance, if the benefits are large or small. And that leads to developing the recommendation. If the recommendation is exactly the same, nothing has changed, when the ETD judgments are actually addressed and no new evidence has been necessary, then it's an adopted recommendation. It's adapted if it changes either the judgments or the direction and strength, the wording. And then finally, if no existing recommendation exists, it requires a de novo development process in order to fill important gaps that a local group might have identified. So here is how we've what is a very brief summary, and I will focus on this point because it's been asked on a couple of occasions. Adoption in the context of adultment still means contextualization without changes. I want to be very clear about this. I think it would be a mistake to believe that recommendations can be used in a specific context without checking that the evidence actually is applicable and that the judgments are the same. I stop here because we're also at the top of the hour. There are no further questions or comments. Anything else in the chat? Yeah. Oh, Yasser Young is asking whether or not, so adultment, we've now done a systematic review and there's about 30 papers describing adultment. So I think it's more than you. And there's probably more, but you absolutely need guideline skills, right? And GRADE ETDs are, are the method of choice, right? I would say I wouldn't even want to use a guideline that doesn't have an evidence to decision framework, regardless of if I adopt it, adapt it, or use any process, simply because that transparency is necessary whether or not you are doing a contextualization formally with the guideline panel, or if you do it as a single partition. You want an ETD to be there. And therefore, this is obviously the backbone, but it's a requirement, I think. Yeah. One question from Christine. If the source guideline used a similar question as what you're interested in, same intervention, but examine different outcomes of interest, can you still use the adultment approach? Yeah. So interesting point. That falls into what we, in order to conceptualize it, that would likely be an adaptation effort, Christine. And the way to think about it is, let's just say that indeed there is an outcome that the new guideline panel those who are adapting are interested in, and it is not addressed in the source guideline, it means that you have to go back to the original either systematic review or identify the information for that outcome if it's not part of the review in the evidence profile of the source guideline. And it's still an efficient way to do things because all the other outcomes are there, but you might have to go back through the original papers and at least address the outcome that is there. That would lead to an adaptation of the recommendation, I'm quite sure, because it's unlikely for everything to be the same if you add outcomes. Oh, great point. So, David, how to use some adultment, how to convince people to use adultment. I agree with you. You know, most guidelines have been quite bad in terms of the quality, and with our recommendation mapping, we found big quality deficiencies, in particular now in the COVID era, right? So it's a real problem. Quality is still a big problem. But what I didn't explain in detail, but we will spend more time on, is that the quality assessment is part of the process. So you should do an independent quality assessment of the source guideline, obviously using Agree or whatever tool you prefer doing, before you actually start adapting the recommendation. And what we suggest, David, is that this is not a per guideline process, but that it is a per recommendation process, because an Agree assessment on a guideline level might not actually be sufficient, because guidelines can have deficiencies in single recommendations by not having done a systematic review for a single question. Yeah. That would be, so how to convince people, saving time and looking at the, you know, we're putting this systematic review together, looking at the successful approaches that are there. I think the European breast guidelines are really a great example for where a central, maybe for the first time, a central repository of ETDs was shared and utilized in several countries, right? Starting in 2019. And I think using these examples is quite helpful. And the European Commission was quite open to share this, as I said, so not only within Europe, but with some countries like China, Tunisia, and Chile, and I think Canada, if you think of it as in the global context. So that is the type of approach that we need. And then Graziella has it, is it possible to first identify the GRADE guideline and after choose the better people question with the guideline? Of course you can do that, Graziella, you can absolutely do that. I think there's always a little bit of a risk to not identify. So let me be more nuanced. Of course, you might look at existing guidelines to see what questions you might have to prioritize. Because sometimes you don't think of all of the questions. The guideline panel, the national guideline panel, may of course be informed by what recommendations are out there in the source guideline. But what is really critical is to then also say, okay, we have this question bank, 100 questions. But at the same time, despite these 100 questions and recommendations that we have here, there's still 5 that are missing because they are relevant for our context. So yes, you can of course start with that, but you should absolutely go into details. Yeah. So, and Yasser is putting the big database for GRADE and clinical practice guidelines there. That's a great resource maintained by the WHO of all GRADE guidelines. Thanks, Yasser. Okay, I think we have to stop.
Yeah. Thank you so much, Holger. That was a super presentation. Thank you so much.
And more on the 20th of December.
Yes.
Thanks all. Thanks all. It was a real pleasure. Thanks for attending. Thanks for being here.
Thank you so much. Thank you, Holger. I wonder on part 2 will be something about the development function of the e-COVID rec map? Or
Yeah,
I know there's a separate presentation for this, but
yeah, we will
Okay,
include
great.
we will include that. Yes, yes,
okay,
yes.
great. That's great.
Great. Thank you so much, Holger.
Thanks everybody. See you soon.